I apologize for being a few minutes late. Was just briefing the commissioner on another issue. Thanks for your patience. It looks like we have about 20 participants, so we're going to go ahead and get started. Um, this is a meeting of the Palliative Care Benefit Work Group, and our purpose today is to hear from Milliman on their draft actuarial analysis report in terms of a palliative care benefit. We're recording this meeting. It'll be posted on the work group's public webpage after we hear from Milliman and open it up for our work group to ask questions, give feedback. I'll lay out some of our next steps and dates for your ability to review this further and give us written comments, and then our timeline for the final report and when OIC will be delivering that to the legislature. So with that being said, I'm going to turn it over to Matthew and his team from Milliman to tell you about their draft actuarial analysis.
Thank you very much, Nico, and good morning or good afternoon to everyone in case we have anybody who's dialing in outside of Washington State. As Nico mentioned, we are here to talk about our palliative care report. This is a multi-step set of deliverables that we're providing to OIC, where the final report will be delivered to the state to support their deliberations around a potential palliative care benefit. This is the third of our draft reports, and this report specifically focuses on actuarial analysis, with previous ones focusing on clinical data and other points. This is pulling a lot of these together to generate overall projections, and then future reports will also take into account a potential pediatric benefit for members under 21, as well as certain scenarios that may be of interest to the work group or to the state. Any questions around that before I get started before I start talking about some of the detail?
Can I just ask a procedural question? Do you want questions as you're going through the report, or at the end, or not at all, and we submit them later?
Just to be clear, we absolutely want to have questions. My thought is that I will give a relatively brief overview of the report, and then probably about just a few minutes, and then we'll really have time to dig into particular sections you may want to find more interesting, particular questions you want to ask. But I view this as largely the purpose of this is to have a back and forth discussion with the work group, make sure we're on the same page, address any questions. And with that in mind, let me see if I'm actually able to share my screen. Can people see my screen?
We can, yes.
Okay, perfect.
If you're able to zoom in a little, that would be really helpful.
Sorry, zoom in a little? Absolutely. So this is our draft report, which I believe has been forwarded to all members of the work group. So if anybody has these pulled up, feel free to follow along. I wanted to just go over a couple of high-level points, and then really we'll have time to dig into particulars of our analysis, some scenarios we may be discussing for the future, or really any other topic that may be of interest to the work group, however that conversation may go. But broadly speaking, as we had noted, previous iterations of our reports have talked about the clinical eligibility criteria, the services included, staffing issues, evaluation criteria, et cetera, as well as payment models. This report is really here to provide some numerical support, with final reports having some additional numbers, really building out the detail. This is really here to get at the high level bottom line. Here's about what we're looking at in terms of a projected cost. So overall, just to get into the key point, we have projected 2,027 per member per month costs across the entire commercial population as well as the Medicaid population. We have separately analyzed data from both Seattle and outside Seattle based on zip codes that are in the broader Seattle area or not. We have overall found relatively similar costs, which we think makes sense because ultimately the cost of the palliative care benefit is that utilization table that we've provided before, with cost per service that was developed separately for commercial, Medicaid, Seattle, non-Seattle. So we do have a little bit of variation in cost based on that, as well as the eligibility from the APC data that says, here's the percentage of the overall population that would be eligible for this benefit in the commercial market, in the Medicaid market, around Seattle and everywhere else in the state. Overall, we projected between 20 and 30 cents for the commercial benefit per member per month. And just to be clear, this is an allowed medical cost. This doesn't factor in any potential cost sharing, since the cost sharing of a benefit would be a to be determined item. It could be no cost sharing, it could be significant cost sharing. Rather than model out those particular ones, we focused really on the allowed cost of such a benefit. So we've got about 20 cents on the low end, about 30 cents on the high end for commercial, with the range really depending on Seattle or non-Seattle. Similarly, on the Medicaid side, we had between 70 and 80 cents. We show to the penny for the values we calculated, but I do think it's probably helpful to think of this as something of a range, because there always will be a little bit of noise. Trends will vary, population eligibility, et cetera. There are a lot of important assumptions that have gone into this. One of which is that, as we've previously discussed, we are breaking out episodes between what we call tier 1, moderate complexity, and tier 2, high complexity. High complexity will have more services and the particulars of whether a member is eligible for tier 1 or tier 2 depends on a number of different clinical eligibility criteria. We can go over those in more detail if it's helpful, but since that has been previously discussed, I don't want to re-go over that unless that's a point of interest. Other important points are, and I'm actually going to skip ahead for a quick sec just to show you, in one of our appendices, we show our overall calculations of how the 22, 30, 80, and 73 came about, which is we'd use the APC data to say in 2022, how many members would have been eligible for this benefit. Then we had a take-up rate assumption of about 15%. This is based on other studies that have been published. We've seen a significant range, as low as 1%, as high as 30+%. Given the data on hand, we considered that 15% was a reasonable high-level assumption. I would expect this to potentially vary, especially as you get into some of the more detailed populations. For instance, an elderly population may have a higher take-up rate, a non-elderly may have a lower, et cetera. But since at least right now we are looking in aggregate, we used an aggregate number of 15%. From all of that, we have utilizers per 100,000. We calculated a cost per episode, and all of those adding up give us a cost per member per month of 22 cents, 30 cents, 80, and 73 cents. One of the other important items, which you may want to talk about further as we go through, is the discussion around cost savings. We have spent a significant amount of time reviewing existing research on the topic of potential cost savings from palliative care. In particular, we really focused on non-Medicare, non-hospice palliative care services, because that is the market we're looking at. So hospice is sort of its own world, and that's a little bit different. When we've reviewed research, we found a lot of important issues or challenges associated with them. One of them is significant variation in studies population, benefit design, line of business. A lot of these are Medicare focused, and a lot of these are end of life focused. A lot of the studies out there really focus specifically on hospice as opposed to broader palliative care. And one of the other points is that many of the savings that some and not all of the studies have noted seem to be specific to the existence of hospice or members transitioning to hospice. And some of those savings appear to not directly factor in the cost of hospice. So if you consider hospice to be a non-medical cost, and then you're looking at medical savings, you can see savings because the cost of hospice isn't necessarily included. We found certain other observations on individual studies one way or the other, but broadly speaking, it is our opinion that the most appropriate assumption to be using for the sake of this analysis is that there will be no direct medical savings simply due to the existence of a palliative care benefit. However, I do want to see what everybody thinks, and we're happy to have a conversation on that. I'm also happy to delve into the particulars of what we did on the clinical side, how we developed the analysis plan. Really, what I want to know is what everybody's thoughts are, and we're really happy to take whatever questions you may have and dig into things in more detail as you find helpful. And with that in mind, I think I would actually like to turn it over to the group now rather than spend another 10 or 15 minutes going through every page of the report, since I believe people have had a chance to look over. But if anybody would like me to talk in more detail on anything in particular, excuse me, I'm happy to do so.
Thank you, Matthew. Um, if you can find it, please use the raised hand feature, and I can call on people. It's just because we have a lot of people on the call. Go ahead, Chris.
Sorry, this is just a quick question about the data. Is Seattle region just King County zip codes, or are there zip codes outside of King County included in
I believe
Seattle
it
region?
was CSA zip codes. So it's not precisely King County, but it's the broader CSA.
Thanks.
I see Mara's hand up next. Go ahead, Mara.
Great. Since I am I'm a nurse practitioner clinically, I know nothing about business, administrative, financial things. To me, the cost per member per month seems really low. Like, is I'm just curious, like, what can we compare it to insurance wise spending on other things?
Yeah. So the real thing the big thing that's driving the per member per month cost really low is the fact that very few members would be eligible, and of those, relatively few would necessarily use the benefit. So when we look at the data right here, eligible members per 100,000 in commercial, you're looking at about 100 per 100,000. Outside of Seattle, it's like 130. So that immediately really slashes the cost. You do have more eligible members in Medicaid, but even there, you're looking at significantly lower than 1% of the population. And then among those eligible members, we're looking at a projected take-up rate of about 15%. So even though some of these costs per episodes are pretty substantial, 8,800 in commercial Seattle, 9,200 and change commercial non-Seattle, 45 to 5,500 per episode for Medicaid, the overall take-up rates and eligibility really slash that in terms of how that would project to the broader population.
Okay, and the cost per episode would be the time that they would be on the palliative care benefit, like the palliative care.
So this would be
period.
an 6-month episode. And I do want to clarify that because there may be members who have multiple episodes.
Right.
So a given member, 6 months, and then they may have another 6 month, they may have another 6 month. It's not cost per member over their entire benefit. It's cost per member on that 6-month period.
Okay. Great. Thank you.
In my recollection, we didn't want to assume a take-up rate that was really inconsistent with practical experience of previous services. And I think that was one of the goals here, because that could lead to a per member per month rate overall, a cost that might not be realistic with real world experience.
And one of the things I do also want to note is that as this benefit continues, as you go beyond 2027 to 28, assuming this goes through and assuming it was 1/1/27, in 28, 29, 30, et cetera, you could see an increase to the take-up rate as it becomes better known, as providers refer members to palliative care providers, as there's less of a stigma. There are lots of reasons why this number could go up over time. We've really tried to focus it on what does it look like year one, but with the knowledge that this could increase potentially materially as time does go on.
So I think I'm next in the question queue. On page 1, you listed the key assumptions, and it was 0.65% of the Medicaid population. And I just wanted to confirm, is that Medicaid population approximately 2 million in the state?
I'd have to double check the exact numbers on that. We did combine all rate codes. And just to be clear, this was the adult Medicaid population. So all members
gotcha.
under 21 have been excluded in this. We are going to follow up with some analysis on the under 21 population, but this was specific to the 21 and up population. So it wouldn't be truly all Medicaid. It's all Medicaid adults.
Okay. And does that include dually eligible Medicare and Medicaid?
I believe so.
Okay,
Although
okay.
for those members, you will get somewhat of a different experience in that Medicare does pick up some of the costs, although not palliative care. So
Yeah.
when it comes to looking at the overall total cost of care from the state perspective for dual members, you would get something a little different. So if we start talking about what the total cost of care looks like, you would potentially get some different implications there. You would also have a much higher, presumably a materially higher eligibility rate because this would be an elderly population. So those are considerations.
Right.
If it's of interest to look at different rate groups and how the population breaks down into more discrete cohorts.
Great, thank you. Then the third assumption on page 1, I just wondered how you defined non-palliative spend, because I think that can be hard to parse for
Yep.
some.
Of course, hold on, let me
diagnosis.
just, yeah, so in this case, I just mean overall medical spending. So the cost both to the state on Medicaid, to commercial payers in the commercial market. Part of this also is that, for instance, hospice, depending on who you talk to, may be considered a medical or a non-medical spend. For the sake of this analysis, we're considering that as part of medical spend, particularly on the Medicaid side when the state is responsible for that, rather than trying to parse that out. Because
Okay,
even
thank
if you have a specific market where a given payer isn't paying for hospice, somebody's paying for hospice. So
Yeah, right. And then on, let me see. Let's go down to page 5, if you don't mind, on the palliative care service units.
Yep, of course. 1 second.
And how those are defined, because and this is just me speaking, but I would hope that if and when this leads to legislation, and I think it will, final report will weigh heavily on that. I would want to make sure that those different service categories, there's no restriction on, for example, which could be provided through telehealth as opposed to an in-person visit. I think that would be an important detail to include in the legislation. And then which staff people could provide these services. For example, does the initial assessment have to be done by a physician or an NP or a physician assistant, or can some components of that initial assessment be completed by an RN or a social worker, perhaps?
Mhm.
And I know in a couple of communities in the state, there are some pilot projects where EMTs are being looped into helping to provide palliative care. So I would just hope that there's no restrictions that limit, who can provide these services. And it may vary from community to community for the palliative care provider. And so some may use community health workers, for example. And I just hope that whatever language is included in the final reports, it doesn't prescribe who can provide these services. And so that was just the comment I wanted to make about this list, because it should be up to each palliative care team to decide how to best meet that patient's needs. So anyway, I'll get off my soapbox about that. But and then if we could scroll down to page 9, and I promise I'm almost done, and I'll give over time for other questions, where you talk about the take-up rates, basically. I think it's on page 9.
Oh, sorry. The suffix
Yeah.
page 9. The PDF has a couple title pages. That's
Yes,
why.
that's right. Yes, I know. Yeah, take-up rates, and that feeds into the second assumption that was on page 1 for the 15% of eligible enrollees. So you base that assumption on this. But I think it's skewed because of a lack of availability of palliative care around the state, around the country. I just think that's a hard number. And I'll defer to Greg and others clinicians, because I think if it's available and it's readily known that it's available and it's covered by someone, a patient, if you build it, they will come. So I just wanted to provide that editorial comment. I think that number, it sounds low to me, but I could be wrong.
Yep, no,
And I
would you
think
mind if I
that,
give a quick response on that, and then we
please.
can add? Okay, so on the take-up rates, one of the things I'll note is that this was really focused on a year one estimate, and I do think that there is the potential for year 2, year 3, or year 4, year 5, as more providers are exposed, as the population becomes used to it, that you could very well see a materially higher take-up rate. I'm a little skeptical you'll get that immediately off the bat, especially if this is a 1/1/27 benefit, because it likely will take some time to build up networks, to find more providers, to educate people. But I do think that there could be the potential for that to swing over time, just like there could be the potential for eligibility to change over time as more members are aware of this, as patterns of care shift, et cetera. Carol, did you have any other comments on that specifically? Because I know there's a clinical component. I don't want to skip over you.
I don't. I think that like many programs, right? Like it's a referral issue or a referral issue. There is an availability of palliative care in the community, which you might expect to be lower in the beginning, just in terms of the take up. But then there's also the referral issue, right? Like explaining, communicating to people what this is, and getting clinicians who have patients in a curative care pathway to actually refer patients, right? This can impede hospice referrals, but it can also impede palliative care referrals. And there are many publications suggesting this is the case. That's why our thinking was conservative take-up estimates to begin with, so as not to overinflate like unreasonably the cost of the bill for the early years, understanding that this might change over time.
Yeah. Okay. Thank you.
Barb, did you have any other questions? I know you had some thoughts, and I just wanted to make sure we were addressing your points as they came, but if you have anything else, happy to talk through those as well.
No, I appreciate your responses. Those were the questions I had from reading the report. Thanks.
Let's go to Greg, because I know he's been waiting a while. And then, we can circle back to this conversation on take-up rate and consider it more. I think it's really important. Go ahead, Greg.
Thank you, Nico. A few different thoughts. The first being, I'm a little concerned about the assumption that the costs of hospice would be basically equivalent to the costs of non-palliative medical interventions. As a clinician, my observation is that hospice reduces emergency department visits and hospitalizations in a way that the net costs would be substantially lower for somebody being in hospice in the last 6 months of life than somebody doing quote unquote usual care. And so I would want to have a little more meticulous comparison, a data-driven comparison of costs for hospice, as opposed to just the assumption that, oh, well, there are still costs for hospice, so we're going to make that a wash. Second point, I have come across some data that I shared with Nico. I don't know if it's gotten to you, Matt, and others, where both at least one study was with Aetna, so it's a private insurer. Other studies were Medicaid-based, demonstrating fairly substantial cost reduction that I would want to see included in this report. If we're going to go to the legislature asking for something that has significant costs, and we can demonstrate an effective cost reduction, an evidence-based cost reduction, I'll trust you guys on the actuarial analysis of that evidence, because that's not my bailiwick. And then the third element Barb alluded to that I think needs to be important. Some of this is outside the scope of our work group, but we at least need to acknowledge it, which is a lot of these individuals are going to have difficulty going into a clinic or have difficulty having a service come out to the home. And so telehealth is going to be a crucial part of this. I just, every single work day in the hospital, I'm talking to people about when you leave, we don't unfortunately have a telehealth component to be able to serve you. And if we had telehealth more broadly available, I think that would also impact the take-up rates and really serve particularly the rural communities, but I think urban communities as well. So those are just some observations I wanted to include.
Yeah, and thank you for reminding me of the telehealth point that Barb, because that's also, I think, related to what Barb brought up earlier. Just to clarify, our analysis is not prescriptive on any policy recommendations or anything like that. What we've done is we've modeled cost based on parallel or reasonably similar services to the extent possible that we found in APCD, and looking at what are the average costs of those. This isn't reductive or restrictive to say that you cannot do telehealth, you cannot have alternative providers. That would be ultimately a decision where the state would decide what sort of providers and what sort of environments would be eligible for this type of a benefit. But we have not specifically envisioned any particular environment based on relative restriction levels. So that is not something which would be making it into our report if there's any concern on that one. In terms, Nico, I know you had sent us a number of items. The items that Greg sent, was that included in what you have sent us or not? I just don't remember off the top of my head the series of emails. So
Yes, I
think it
believe
was,
so.
but
And I think that was on the same day that Greg sent it.
okay. Yeah, so we have looked over all of those. I may add an additional note specific to those studies, as we've reviewed a lot of different studies, so I don't have a note on that on hand, but I am happy to follow up with some additional on those specifically. I just don't want to give an offhand comment that may not be relevant to the items that you had sent. And I think you had a third point that you brought up, and I may have glossed over that in responding to the top two. So was there a third point that I had missed responding to just now?
I think maybe the one that didn't get addressed is the comparison of hospice to regular care.
Yes, thank you. That was the one. Carol, did you want to hop in with a response or?
Yeah, I mean, I think that like there's data for a number of studies showing that actually, like if you were enrolled in for 6 months of care for hospice prior to death for that whole period of time, under at least a Medicare with Medicare as a payer, that costs more than matched people who are not enrolled in hospice. There's like a sweet spot because of the way at least Medicare reimburses hospice on a per day basis that is not insignificant. And that sweet spot might be a shorter period of enrollment in hospice of 2 to 3 months, where you, like, if you have too short a period of enrollment in hospice, right, there's sort of no savings. And that period of time, typically, of where hospice actually might have been, has at least have been shown and modeled to be cost saving, is actually shorter than the permitted, like, than the allowed sort of 6 months that we typically think of. So there are issues around entry into hospice and sort of the impact of that. Entry into hospice is not always a cost saving. It can be a cost adding measure if the entry into hospice is enough in advance of death that that the patient is enrolled for a long period of time. Again, at least in the Medicare world. And I understand we're not talking about Medicare, but that's where like most of the studies have been done. And so when Matthew talks about sort of the issues around like the timing and the changing of hospice enrollment and how that's been included and the cost of hospice in studies, I think I just wanted to sort of raise the fact that like I think there is evidence that hospice entry can be cost savings as you describe, but it really depends upon the entry point, right? And because the trajectory from palliative care to hospice is unknown and has differed in a number of analyses, that hospice entry point has a substantial impact on sort of what kind and how hospice is considered spend on what might be measured around cost offsets from palliative care, for example.
Yeah, I would also just make one note before we move on, is that to the extent that this benefit is envisioned as a longitudinal benefit, for some members may be there for multiple periods, that this is not expected to be necessarily you get palliative care and then it will, for instance, hasten your entry into hospice by a month or two. That may be part of what's envisioned, but from our conversations, my understanding is that it's also envisioned as a longer term benefit for at least a chunk of the relevant population. Then for all of those more longitudinal members, the relative cost savings or additions from hospice becomes a little bit moot, because it's really what is the direct impact of palliative care interventions, which that's one where a lot of the studies really focusing on Medicare and hospice population tends to be more difficult to tease out something specific to non-palliative hospice care as well. Nico, was Heather the next person with a hand raise is popping on my screen, but I don't want to go out of order. If
Yeah, I was just pausing on this like particular topic, because I think it's a really good one. Yeah, let's go to Heather. Go ahead, Heather.
I think Matthew answered part of what my question was going to be, because it seems like in the cost discussion, there is a heavy focus on folks who are receiving palliative care who are right adjacent to being in hospice. And I am wondering about the population of individuals who would benefit from palliative care who are not close to hospice, and the cost savings from those folks not going into the emergency department, not being admitted to the hospital for things that could be managed on an outpatient basis. And I'm curious if there just wasn't evidence that supports that, just sort of common sense thought process of thinking through where the cost savings would be. And if most of the cost impacts are focused on folks that are toward end of life, because I feel like there's a little bit of blurring that's happening with palliative care recipients and hospice recipients.
I think that's, sorry, Carol, did you have a?
I
think
was
you
just
had
going to
something.
comment and back that there's literature in this area. You're right that a lot of that literature focuses on people who are maybe closer to an end of life trajectory. There are papers, including some of the ones that were just re-forwarded, that talk about or model cost savings. Sometimes they're not actual cost savings, measured cost savings. Sometimes they're modeled cost savings based on theoretical reductions. What I would say is the literature is highly variable, and the quality of that, even peer-reviewed publications, is highly variable in how it is adequately accounted for factors outside of palliative care that can influence the cost trajectory of people. And in like our global assessment of literature, there's really not sufficient information to allow us to say that community-based palliative care of the type of benefit design for an eligible population being considered for Washington would have cost offsets. Again, some of the stories are single program, single institution. The models are different here. The patients that are targeted are different, and the findings are variable, and the methodologies that underpin those findings, in many cases, I would say, are relatively weak in terms of they haven't accounted for substantial other factors like regression to the mean. If you enroll people at a high point of spend around something and you're measuring before and after, you can imagine that even in the absence of palliative care, their spend decreases. And so the totality of this is I think we're not comfortable that there's an evidence-based rationale, despite it being logical from your perspective. And we've talked with many people about this, and it does seem logical. But the evidence to support, there are many things that seem logical in healthcare that we actually don't have evidence to support, or studies have shown are not supportable. And so I don't think we're comfortable that there's a sufficient body of evidence to apply an assumption about a cost offset.
Yeah, but also throw in there are a decent number of these studies that are very small populations, which I think is inherent to the nature of what we're talking about, given that you tend to have low eligibility for people who would be relevant, relatively low take-up rates for palliative care. So I think that lends itself to credibility just being a real challenge for any study as well, even beyond all of those issues Carol was just mentioning.
Let me say quickly that towards the end of this call, I'm going to lay out the process that we're going to use for finalizing the report, and how the work group is going to go about any response to the report and the recommendations issue, because I think that's related to our discussion about some of these reports. So I'm going to do that at the end. Let's see, I see Chris's hand and then Barb's hand. Chris, do you want to go first, and then we'll go to Barb?
Sure. As I was looking at the trend assumption piece, I'm a little concerned. I mean, I was shocked that we have a Medicaid trend of 2%, because just about everything in Medicaid, we have some serious trend issues happening, not just in this state, but across the country right now. And so I was looking at the assumptions, and I'm a little concerned for the commercial market. It looks like you used a data set from 2022 to 2027 projections But for Medicaid, it's 2014 through 2023. So you have the pandemic, you have this growth in membership, and there's no redetermination built into that data set. And, post 2023, you have this shrinking of the Medicaid market. We have, increases in utilization, increases in cost. We have this huge acuity trend. There's nothing in here that says that was taken into account or that you looked at anything. Is this really just a data set that ends in 2023? And if so, what's the plan to kind of focus on the acuity piece that we're really seeing and struggling with right now?
Yeah. So just to make a quick note about that, particularly on the Medicaid side. So this is focused on a per member per month trend that we've seen overall. So to the extent that redetermination has a significant cut, or to the extent that the population of Medicaid goes significantly up, down, there may be some differences in the remaining population versus the persisting population, which may be material, but it's not, for instance, you double it or you cut it in half, because this is still focused on a per member per month. And also, just to be clear, what we are doing here is looking at Medicaid data for average charge per service. So when it comes to acuity going up, people using more services, people using less services. So when it comes to, for instance, looking at a total cost of care number, then you might see some more significant ranges of trends are going more up, trends are going more down. But when it comes to really just what is the overall trend for charge per service, we consider that a historical look at the Medicaid data over a longitudinal period of about a decade. We consider that to be pretty reasonable. I'm not saying 2% is going to be exactly the right answer, because particularly in Medicaid, you do see things going up and down. It's not like it was a flatline 2% or anything like that. But we would consider that to be relatively reasonable. I will also note that in terms of the bottom line results, you'd have to see a pretty significant change to your trend assumptions to get a change to the overall result here that we would consider material. So just going back to here, for instance, if you're looking at a per member per month between 20 and 30 cents in commercial, you'd have to have a significant percentage shift for that number to be significantly different. And that's also true on the Medicaid side. If you were to go from 2022 to 27 and you said, well, what if we use 3% instead of 2%? That's going to be plus 5%. This would be 80 to 84 cents. This would be 73, becomes 77. The numbers would be different. I would not say that the conclusion would be significantly different. And also, just to be clear, this is a model of the broad expected cost of what we've modeled as a benefit. This would not be the state is saying, we are done. This is exactly what it's going to cost. Put this into your fee schedule increases, put this into our Medicaid projections. More work would certainly need to be done in terms of actually plugging this in based on the actual benefit assigned, based on updated data. As assuming you were to do a 1/127 analysis would be updated given more recent data for both commercial and Medicaid. So there would be more to it in terms of actually plugging it into the market. But I don't know that any of those items would significantly change this. I don't think it would be reasonable to look at this and say, well, that 80 cents is going to go into $5 based on trend changes or something really extreme. So I would agree with you that you would see some differences, and 2% may not be the exactly right number, but I do think it's reasonable overall in terms of what we are seeing.
Okay, thanks.
Go ahead, Barb.
Yeah, my question actually is for you, Nico, and perhaps for Jane. So I think I was confused in my own head that this was the report, but this report has to do with the payment models of one of our objectives, right? There's a separate objective that talks about staffing models and the skills that and clinicians who need to be available, and that's what I was getting at earlier. But that will be part of the group's final report, right, to the legislature, sorry.
Yes, it's
yeah,
a good question.
Yeah, thank you.
And our first report had really dealt with that specifically. And when we have an overall draft final, we'll be reincorporating that. What we've tried to do is simplify these into pieces so that we can really focus our discussion on this issue or that issue or these couple of issues, rather than giving you a 50-page, 100-page, whatever that may look like, just because that becomes a lot more difficult to digest, especially if a lot of this is stuff you've already seen. And we really want to focus on stuff you haven't seen or stuff you've seen that directly points to, you've seen some stuff on the analysis plan, and here's how that points to supporting the numbers, as opposed to all of the other things, which are important, but not directly related to the financial projections we've got here.
Okay, thank you.
Barb, to answer your question, there's going to be one final report, November 1st, given to the legislature, and that's going to combine, roughly, it's going to combine the existing drafts that Milliman has done, although those are drafts. So we're going to be working with Milliman and with you to combine those pieces and then make any further changes. So it'll be all one report.
And we'll be meeting weekly in the month of October, right? just
Well, I'm gonna lay out the process, but I mean, we're very open to meeting with you, Barb, and anyone else as you have questions. So
thank you. Well, this group has a lot of opinions, as you've seen.
Well, we appreciate them because we want to make sure that this is the best report it can be. And we want to make sure that we are, we don't agree with everything you say, but we are considering each of the points you make so that everything you see is going to be handled as appropriately as possible.
well, so I was going to cover this at the end of the call, but I'm just going to say this now. Because, I mean, the legislature has set up this work group to advise this process. You have a lot of expertise. We want your views to be incorporated and covered at least in some point for this final product. And so part of the feedback that I'm going to be soliciting after you review this draft is to give you as the work group the opportunity to write your comments responding to the report, to the final report, and give any recommendations you want to. And I'm going to have those as an appendix to the final report. So as you're doing your comments, think about those pieces. And I think it's going to be most relevant for when you're looking at the combined final report that we're going to be going over at the very beginning of October, which is going to be about a month before it's transmitted. So I'll share this timeline, but I'm going to give folks the opportunity to do that and include those as appendices if there are big points that work group members disagree with in the analysis. Any questions on that? Okay, any other questions for Matthew or Milliman on the substance of this analysis? Going once? Going twice? Okay, Matthew and Milliman team, I do have a question from me that is substantive, and we can talk about this more on our upcoming calls with you individually, but there's a part of page 3 when you're talking about the overall medical cost projections where you
Yep.
say that you assume no offset to these costs for any services currently utilized under existing medical benefits. The take-up rate may increase in future years due to greater visibility, expanded provider coverage, and other factors. Okay, so I guess it's really just that sentence. We assume no offset to these costs for any services currently utilized under existing medical benefits. And I think my question is, because my assumption is that there are some palliative care services and benefits that are currently being covered by insurers in commercial and Medicaid and being reimbursed, that we're not talking about an entirely new group of services. And so I'm wondering how you thought about and how you analyzed any palliative care services you determined are already covered and reimbursed. Does that make
Yeah,
sense?
absolutely. And that's a really great question. I'm going to let Carol respond to this as well, but I just want to give my quick thoughts from a numbers perspective. So a couple things. One thing I would note is that to the extent there are palliative care services offered, some of those may be offered for members who are not eligible under this benefit. So if you have palliative care services under some other condition that's offered either in Medicaid, under some insurer, as well as obviously the under 21 Medicaid, which is a separate thing that we'll be talking about later. But just looking at the adult population, to the extent that palliative care services are being offered to members that would not be covered by this benefit, which maybe some of them, there would be no offset because that wouldn't be necessarily relevant. It would really be focused on the members who are actually eligible. And basically, in our analysis, we did look at analogs to services that may come in parallel that aren't necessarily palliative care. And let me scroll down just to the list of services so we can talk about that more directly. So for instance, there may be some, office visits that might parallel what would happen in the initial assessment, whereby you may not have as many regular office visits because you've got the initial assessment, because you've got certain these other things. That isn't necessarily palliative care, but it is possible there will be some offset. Some of these broader categories of service may parallel things that are palliative care, but aren't necessarily directly palliative care. And some of those might potentially be offset because palliative care providers. So for instance, if you've got certain behavioral health services, that may not be palliative care in the overall definition because it's under a different umbrella, but you may have less demand for those services because you have this benefit. I would just be cautious in noting that not everything under these categories is necessarily a palliative care benefit, and we wanted to be reasonably conservative about not necessarily assuming that all of those services or even a specific portion would necessarily go away. But we also wanted to be explicit about the assumptions we are doing so that there isn't confusion about this point. And I think, Carol, you probably have some additional thoughts.
Yeah,
well.
I mean, I would say like we don't actually have a reliable way to sort of identify those services that maybe not in the community-based palliative care construct are being paid for as palliative care services by payers. I think the most common services that we see that are palliative care related are hospital-based palliative care. That's sort of a different population and a different model than this. And so like general behavioral health services, for example, that patients have that would not be potentially needed or not be needed to the same degree with the benefit with the availability of a community-based palliative care benefits such as these. Like we would expect those to sort of be represented in any kind of medical cost offset that is being that has been measured in research, and we talked about medical cost offsets. So I think part of the issue is like in terms of outside of a benefit, sort of if there are, we'll call them palliative care services, symptom management, this is part of the regular practice of medicine. In addition to the eligibility issue that Matthew mentioned and other people who might be having them, there's really no way for us to separately distinguish those services that currently are paid as palliative care services or would be covered as palliative care services. There's care people are receiving medical services. A lot there isn't payment by some payers or many payers for a lot of the types of services we're talking about here in the form that they're being provided. And so we can't really say that this would substitute for these following set of services that are currently covered and paid as palliative care services because there's really no ability to distinguish office visits that are palliative care oriented versus symptom management in a person on a curative trajectory versus diagnostic and treatment related to make such kind of an offset assumption.
Thank you, Matthew and Carol, for the explanation. Does anyone from the work group or our participants have any follow-up to that, the question I asked in the response? Okay, it's 10:52. We have about 8 minutes. I have some dates to give you.
I think Greg
Yeah,
may have
go
just
ahead,
raised his
Greg.
hand. Sorry.
Had to get off mute. Just one question, and I should know the answer to this. How much have we compared the work we're doing with states that have already developed Medicaid, in particular palliative care benefits, California, Hawaii, Maryland? I know that I've seen some information on that, but I'm just not sure where we stand on it.
When you say in terms of comparing, do you mean in terms of developing, what are the projected utilization rates? Do you mean in terms of
Oh,
the cost per service? Can you clarify what you mean in terms of
no,
compare?
thanks for that clarifying question, Matt. I was thinking specifically of the budget neutrality because my understanding is that some of the states that have done this have found, at the very least, it doesn't increase the cost of the Medicaid services. I don't know that it's demonstrated cost savings, but at least it doesn't demonstrate any added costs, is my understanding. But I don't know the data all that deeply.
Quick question. Carol, did you have a thought before I give a couple of my thoughts, or should I just start on that? Okay.
Just
So-
start.
I'm sorry, go ahead. Okay, yes.
No, I would
okay.
say go ahead and start. Sorry,
Yeah,
I'm taking myself
so-
off mute.
No, that's fine. So we have looked at data that's available where we can. I think there's been more limited resources in terms of reports specifically on, let's say Medicaid states. And if there's a report or two that you think we should be specifically looking at for additional commentary, we're happy to look at that as well. I think you had sent some stuff. I don't recall if that was in the packet. Our overall focus has been on assessing, just broadly speaking, studies, reports, et cetera. I don't think that we had specifically focused on individual states that have done something like this, in part because I don't believe that what Washington is looking at is directly analogous to something specific for another state, because every state designs these differently. But to the extent that you've got something else that you want us to add in of, because there have been states that have contemplated this, we're happy to look at that and provide additional commentary. I don't have that in my fingertips just to give you hey, these were our thoughts about this particular state. We've really tried to take a broader look both at Medicaid, Medicare, commercial, basically any sources we can. I just couldn't give you something specific to the analysis of Medicaid expansion off the top of my head.
I do know that Tory Fields put together a packet of reports and information. It's possible that that had some Medicaid specific information. I don't know off the top of my head. We did. I know that Milliman did receive that.
Yeah. From Tory, I can note a lot of the things that were there really focused on Medicare, to my recollection. Like one of the big things that was highlighted was that Medicare study that said, here's the admits that go down, here's the ER visits that go down. And that was one of those which we were talking about in our report that said, a lot of this was specifically due to hospice, as they noted. And again, Medicare isn't directly analogous to Medicaid and commercial. It's more elderly population, year end of life, et cetera. But yeah, we can add some additional comments on some specific reports and states if that would be helpful as well. Jane, I think you've got your hand up.
Yeah, I do. So I wanted to maybe follow up a little bit, Matt and Carol, on the issue that Nico raised about there not being sort of cost offsets associated with services that are already covered under health plans. And a couple of thoughts. When this issue was first brought to the legislature, we were asked the question of whether this was a new mandate. And we looked at the services that were included in sort of a palliative care benefit, compared it to the essential health benefits benefit plan, and found a fair amount of overlap with services that are already covered in the benchmark plan. And Carol, I understand what you're saying about there might be people who wouldn't meet the palliative care eligibility criteria who are using services. But when I think about what we've heard from the carriers, which is, yes, we have case management programs for our higher cost enrollees, right? So we're doing complex, we might have a pharmacist who's on point to help with med management. We're doing assessments. we're doing sort of ongoing management of the case. And so if we have data about sort of what percentage of the population we think would qualify, I'm just having a hard time saying that there's no association with any cost offsets for services that are currently covered. Not at all. And that, right, I'm not saying totally offset, et cetera, but the conclusion that there's no spending that's currently being spent for folks who have these kinds of health conditions under services that are already covered just seems odd to me in kind of a real world perspective. So I don't know whether there's another opportunity to take another look at that or think about it a little bit more carefully. It's just, that's the biggest, actually, when I was reading the report, that was the biggest thing for me that jumped out of the draft report.
Yeah, I mean, one note I will say is that we did, for instance, look at when we're developing our, the data from the APCD, trying to figure out what's the cost per service for an analog to the initial assessment, the 24/7 telephone, et cetera. And one of the things we found is that there was, among the eligible population, there was a pretty low amount of utilization of these services. So like, even if we said, and we're not saying this, but even if we said all of these are palliative care services, all of these would be fully offset. Like if we made that conclusion, which again, we wouldn't make, because what we've talked about, the offset still wouldn't be very large. And so that is one of the considerations we had. Like the bulk majority of a lot of the services we looked at would have actually been provided for members outside of these episodes, members who were never eligible. So you'd get a functional needs assessment for not somebody who's got dementia, just somebody with some other condition. That is one of the considerations we had. I think
What
we're
I hear
happy
though
to.
is a
Sorry, go ahead.
broader question, Matthew, not just we use for pricing. Like there are services we didn't use for pricing that people can receive, whether that be chronic care management, transitional care management. And like what I'm hearing is a request that we look at like the totality of currently received services, not just those we're using for pricing the elements of the palliative benefit, to sort of look at the aggregate of that spending and think about whether the palliative benefit would substitute for those, right? And that is something that is broader than what you're describing in terms of like the spend. That is something we can do. I think there's like, it's challenging for me a little bit to figure out what it would be, right? Because like people could receive home health currently, and some part of what the palliative care benefit would do could replace part of home health, but there's a part of home health that certainly wouldn't be replaced by that, like personal care services and skilled
Right,
services in the
right.
home.
Uh-huh.
And so we'd have to be pretty cautious about what we attributed and potentially might be replaced. But I hear this request, and that's something we can certainly think further about. Just noting that, like, we'd have to make some assessment of what the palliative care benefit could replace for people, at least in terms of like current care management fees that are being paid, for example. Because if those are doing something beyond the palliative care benefit, we wouldn't want to assume that like home health wasn't needed, for example.
That's
Right.
sort
No,
of what I was trying to ask with my, how do you decide what's non-palliative spend,
Mhm.
right? Because anyway, but it's Jane asked it much better and Nico much better than I did.
What I'm going to propose is let's chat with Matthew and Carol more directly on this. But just because it's 11:01, but I really appreciate the discussion. So let's work on that some more. I've placed a little calendar in here, or the dates for everybody, and I'll resend this in an email. This is what we've developed with Milliman for the last few dates. And we're really working as hard as possible to adhere to these dates. So again, we're going to give workgroup members, when you receive the draft final report, the opportunity to put recommendations and responses in, and we're going to put that in as appendices to the Milliman product. if those are responses, right? So these are the dates, and I'll accept additional written comments to this actuarial analysis part by September 5th. If there's any way to send us that earlier, it means we're more likely to make sure it gets incorporated and worked on by Milliman. So certainly the sooner the better. So those are our next steps. I really appreciate everybody's participation with your busy lives and busy schedules. Thank you to Milliman for your work on this project. I think that's it. So we'll conclude. Thanks, everybody.
Right. Thank you very much.
Thank you.